Welcome to Conversations with Kay. I'm Kay Ryder. And every week I talk with Vermonters who are leaders in the fields of government healthcare, education, the arts, and community life. And welcome to our radio listeners at 99.3 FM, WVBT LP. Our guests are from the UVM Health Network, Home Care and Hospice. And we have Judy Peterson, who's president and COO of the agency, and Tara Graham, who's the executive director of Hospice and Palliative Care. Welcome.
Thank you, Kay.
Hi, Kay.
Well, now there's been a big change here. You used to be the VNA, and now you're with the UVM Health Network, and you're still Home Care and Hospice. How long have you been in part of this new network, Judy?
It was January 2018 that the VNA joined the UVM Health Network. And then it was October of that year, October 2018, that we actually changed our name to reflect that new relationship.
How's it going? People still call it VNA? Or?
Sure, sometimes, yeah. You know, I think those of us who are at the organization, I think we're just used to it because we talk about the organization all the time, so we're used to saying home health and hospice now instead of saying the VNA. But lots of times we meet with people in the community who still refer to us as the VNA, and we don't mind that at all. That's a wonderful history. The organization's about 114 years old now. So
right. You have such a good track record that to some extent, you know, it matters what they call you, and yet you have a long history.
Yes, exactly.
Wonderful,
yeah.
Wonderful. Do you feel that this coordination with the hospital has this has been a good step for home care and hospice services?
It really has, and a good step for home health and hospice, but a great step for the people who we serve in the community. You know, that's really what it's about. And the health network is a network of 6 hospitals and home health and physicians. So it really is a system of care so that we're all working together. And so those hospitals, 3 of them are in Vermont, UVM Medical Center right here in Burlington, Central Vermont Medical Center that's in Berlin in Washington County, and Porter Hospital that's in Middlebury. And then there are 3 hospitals in New York who are also part of that system because we have the lake dividing us, but there's just lots of communication and people traveling back and forth. So what's been wonderful about it is that we're all working together as partners to really build this continuum of care so that people get the right care they need at the right time by the right level of provider. More and more care is moving towards the home, and that's being supported by the network.
More and more care at home. I know that you're doing things at home now which were just not thought of years ago. Right. And one of the services you have, which I'm fascinated by, is your telecommunications.
Yep. We do telemonitoring at home. In fact, we were able to just purchase 100 new telemonitors that are video enabled. So that means that it just looks like a little iPad that people can have on their table. And every morning it will remind the person at home to take their vital signs. So they'll take their weight, their blood pressure, their heart rate, their oxygen levels, all very simply by putting just, you know, a little finger caught on or a band on the arm. And that information is all electronically transmitted back to the agency, where we have a nurse who monitors all of this. But the new monitors that the network just purchased for us, as a matter of fact, again, investing in community-based services, the new monitors are video enabled, so that means that the nurse can see the person and talk to them right over the iPad. I saw a wonderful example the other day where the nurse was talking to, the nurse who does some of our longitudinal care program, was talking to a patient on the phone and was saying, the patient said she was dizzy. And so the nurse said, "Have you been drinking enough?" She says, "Oh yes, I drink." And she says, "Well, how much?" She says, "Well, I filled my glass." She says, "Well, show me the glass." So she was able to show her the cup, and she says, "Okay, that's, you know, blank number of ounces. You need to drink 4 of those today." So it was just wonderful, and it could all happen electronically.
Oh, that's great. And, you know, the old saying is a picture is worth 1,000 words.
It's exactly
Yeah,
right.
yeah, and you can really do that. Oh,
Yeah.
that's really good. Now you mentioned longitudinal care. Now what is that?
Longitudinal care is a new program that Home Health started about 2 years ago, so that when people are admitted to Home Health, most people come after some kind of a acute problem. They've probably been in the hospital. They're referred to Home Health. And so we're able to see them for anywhere between like 30 to 60 days. We help stabilize their symptoms. We teach them about how to take care of them, manage their own disease and take their medications, you know, home safety, all of those things that we do. But then Medicare no longer pays. So in the past, we've needed to discharge that person. So with the longitudinal care program, we no longer bill Medicare, but we continue to see them. But just maybe once a month, we keep a telemonitor in their home so we can monitor them. And what we've seen is that people who come onto the program have had a 30% reduction in hospitalizations and ED in the emergency department utilization. Because we know that we don't want to just see them the next time they're hospitalized again. We want to prevent that hospitalization. And that's what this program is about. And
there's nothing the matter with hospitals. When you need to go there, you need to go there. However, most people like to be at home.
Right, and there's certainly a place for hospitals, just like there's a place for nursing homes. But we want to make sure, as I said earlier, people get the right care in the right setting, the right time.
Right.
All that.
Now, there have been a lot of changes, but what hasn't changed? What hasn't changed, Judy?
Right, and what hasn't changed is our mission. You know, that Home Health and Hospice provides this really high quality care. Our mission statement is that we want to help people thrive in their communities. And that's really what it's all about, is helping people take care of themselves, providing services to whoever needs it, regardless of their ability to pay. We bill insurances, but if somebody really needs our care and they don't have insurance, we'll still provide that.
Well, that's been a marvelous thing, and that's been going since the agency started. Because years ago, when I worked at the VNA, I would talk with people who knew a nurse who had been there right at the beginning. And they would talk about, you know, how she would walk at the old North End in Burlington, and she would see families. There was a lot of maternal child health work done then, and you know how much she helped the families, and it was just, they were marvelous stories.
Yeah. Oh yeah. Yeah. And Home Health and Hospice, we see mothers who are pregnant, so we do prenatal, we do postnatal, so the new babies and the families and high-risk families, but families with children who need health care, but then also adults, and we do long-term care, so for people who are staying home and don't want to be in a facility for their long-term care, like a nursing home, and then of course end-of-life care, the hospice and palliative
I'm
care.
I'm going to talk with Tara about that a little bit here.
Yeah.
But you know, it's community now. Now you go to all the towns in Chittenden and Grand Island counties.
That's correct.
And is community support an essential part of your ability to provide all this care for everyone?
It really is, because, you know, as I said, we bill insurances, but we still provide care regardless of people's ability to pay. And we would not be able to do that if it weren't for our donors. We have very loyal donors. We have so many people who regularly give and support the Home Health and Hospice, and we just couldn't do it without our community. Yeah.
Right. Now, recently you had a $2.5 billion budget shortfall. What were the reasons for this, Judy?
Well, there are several reasons. And that is our deficit this year, that it's a operational loss that we cover with donations from our community. And part of it is because about 40% of all the work we do, 40% of our revenue is Medicaid, and Medicaid is insurance for people who are low income, and it's funded through the state of Vermont. Medicare, of course, is the federal insurance, and they pay fairly, but Medicaid does not pay what it costs to provide the services. And we have just a large number of people who their reimbursement source is Medicaid. So there's always a loss for that work.
Right.
But we know how important that work is, so of course we'll do it. There have been other changes in the way Medicare pays home health agencies. And Tara, you were making a good point. Would you make that point that you were making to us a little bit earlier?
Yes. So I believe one of the contributing factors for the increased loss has been with the expansion of the house, which we expanded the house because of
the Respite House.
The Respite House. Thank
Right.
you, Kay. So there was a community need for the Respite House to expand and move. But with that, what we saw an exorbitant increase in was the number of people who didn't have weren't able to pay privately for the room and board charges, because Medicare does not cover the cost of room and board under the hospice benefit.
How about that?
Right.
Well, where do they expect people to, go to sleep out in the street someplace? I mean,
I know. So with the larger house, that's fantastic. It's 21 beds. The old house had been 13 beds. It just is, an opportunity for greater losses, but
Right.
It's that opportunity to provide more care, and we've been doing that. We've served many more people at the new house.
Right. So you're dealing with this, and
Yes.
that's
Yep.
good.
Yeah.
Because people certainly do need your help. Judy, you have where would someone call for information? Now you have a good website, I know.
We do. And the phone number that people can call at any time is 802, of course, 658-1900.
658-1900. It's been that for years.
I was gonna say, you know that.
Right.
Yeah. And our website is uvmhomehealth.org.
Okay.
Yep.
Okay. I'm talking with the people from the UVM Health Network, Home Care and Hospice. And I'm talking with Judy Peterson, who is their COO, and Tara Graham, who is the Executive Director of Hospice and Palliative Care at the agency. Tara, how long have you been the Director of the Hospice and Palliative Care Unit?
I joined the organization in January of 2016.
Okay. So you were there before the name changed?
Yes, I was
Yes.
there before the name change and before the move and expansion of the Respite House.
Right. You like the Respite House?
I love Respite House. I love hospice and palliative care.
This is just a photo of the
Yes.
outside of the Respite House.
Yes, there's the Respite House.
Yeah. I have been there, and I'll let you talk about it, but it's a marvelous place. What is palliative care? When we talk about palliative care now, what are we talking about, and why is it a distinct part of care?
So palliative care is expert care aimed at alleviating suffering. And so hospice is a part of palliative care.
Pain control.
Pain control, expert pain control. So
Right.
it could be for acute symptoms where someone has a need and then comes off of palliative care, but it could be someone has a terminal illness and they are not ready to forego their curative treatments. And so our team will go in and do expert pain control and symptom management.
Well, you need pain control, expert pain control, many times. I mean, sometimes you've had an operation like a knee, knee replacement or something like that. You need temporary pain control.
Correct.
And then you have pain control, which you have been talking about. If someone has a certain kind of illness or in hospice care, they need it. Now, what is the difference between
hospice-
palliative care and hospice care?
Hospice care is a Medicare benefit, and people are entitled to that level of care if they forego their curative treatment. So it's basically electing end-of-life care, their primary care physician and attending physician, as well as our hospice medical director, certify that that person has a terminal illness, which would translate into that if they were not accessing treatment, they would have about 6 months left to live.
Now, I have heard that people do not get into hospice care early enough. Is this true? And why is it important to get in earlier?
It's very, very true. So I was looking at the National Hospice and Palliative Care Organization's recently released facts and figures. That was in August of this past year. And the majority of, 30% of care that's provided is done within 7 days of the end of life. So for someone to really benefit from an interdisciplinary model of care, which is what hospice is, hospice involves a medical director, nurses, social workers, spiritual caregivers, LNAs, homemakers, our trained volunteers, so that whole village of people that support a family and a patient at the end of their life. To have only 7 days in order for that family to experience that, it's really difficult to get in there and do the work that we know that people benefit from. So we'd like to have earlier referrals to hospice, have the community understand their options sooner. Part of that is through advancing the palliative care efforts in the community. You had mentioned palliative care, and our team is part of the Talk Vermont program, which is through the University of Vermont Medical Center, Dr. Bob Gramling. Part of his research has been around conversations at end of life and serious illness conversations, and having those conversations sooner. Our program was the first to engage in that program for earlier goals of care. So to do that upstream and to have it be that people are making goal-concordant goals and wishes about their health care.
Okay, in other words, people are thinking about how do I need to end my life? Mm-hmm. What kind of care do I want near the end of my life? And I want to have pain control, and I want my family to be supported in this effort too. And then, I'll look into hospice care. And hospice can offer a great deal for the family too, can it?
It absolutely can. And just to build on what you're saying, it's not even just about making your healthcare decisions, but understanding what's most valuable to you as you live. And so if we can get people and the people that we're serving to reflect on what's most valuable to them as their life changes, or the things that are most valuable to them sort of slip away, it allows for more conversation about, like, has your treatment goals changed? Because I'm noticing these things have changed for you.
Okay, now let's talk about aging. Now I'm going to be 84. I had to give up tennis. I mean, my body just wouldn't, my body wouldn't let me run like I used to, and I finally decided I was letting my partners down, and I couldn't blame them anymore when things happened. I had to cut it out. And as you get older, if you look at it, people have gone through these steps where they have had to leave things which they used to do, and they can't do them anymore. And I think that this is a spectrum, and so when you're building on this spectrum, if you will, this has been part of somebody's life, and now how do you live until you die?
Right.
Is that what you're talking about?
It is, and it's also acknowledging that people change over time. And so if we took you as an example, Kay, and all of a sudden you started having serious illness, and the doctors were talking about treatment options, invasive treatment options that weren't well researched.
What's an invasive treatment option?
I mean, it could be chemotherapy, it could be a surgical intervention, something that just alongside, yes, something, yes.
Yeah.
So thinking that for you, it would be evaluating that with you about like the risks and benefits, and what does this mean for you, and the things that you love about your life. And so moving along with you with that conversation. So introducing the serious illness conversation if someone's been diagnosed with either a life-limiting illness or a terminal illness.
Yes. Well, and with palliative care, can someone be treated for their pain, etc., and then they decide they want to go into the hospice program if the diagnosis becomes more dire, more hard on them?
Absolutely, and we have many people that are served under palliative care who have not elected their hospice benefit, but are hospice appropriate. So they may have it. So they might be someone who we'd think that would have an earlier transition to hospice, but they're not ready to make that decision, and that's someone's personal right, and that they can decide whether to do that or not.
Do you think that some people have stayed away from hospice because up front you say 6 months approximately to live?
I think that's part of it. I think hospice is affiliated and associated with imminent death, unfortunately, because what we see in hospice is if people elect hospice sooner, they live longer and better. They have a higher quality of life. So I think some of it goes along with how we talk about end-of-life care. often we may say, people in the medical world may say, we have nothing left to do for you. You now can turn to hospice, rather than elevating hospice as a treatment choice.
Right.
Because hospice really is the most expert end-of-life care that someone could receive.
Right. Now, why would someone, now you provide the hospice care in homes throughout the two counties. Why would someone elect to go to the McClure Miller Respite House? Why would they decide, I want to go there?
There's a variety of reasons. The two primary reasons would be that the symptoms are so complex and so concerning that they're difficult to manage in a home setting. So in that situation, we would have nurses around the clock providing that level of support to the patient and their families. The other situation is for folks who don't have primary caregivers. You know, part of our culture, a lot of people live independently, a lot of people live in remote rural areas, and they may not have a family member identified, they may not have someone in the home who we're able to support and educate on how to care for someone at the end of life.
Okay, and let's talk about the way families live now. I mean, my children are out in Seattle and Alaska part of the year, and in California. And I have one daughter who's in Boston. But still, they do not live near me.
Right.
So I would be a prime candidate. My family and I might decide that the respite house was a fine place to go.
And you might decide that you want to stay in your home setting for as long as you can, and then have a short stay at the respite house. It's, you know, it just varies depending on what people's goals are.
Judy, if you're having hospice care at home, can you at any time decide you want to go to the respite house and then it can happen?
Yeah, it's really a decision that happens with the patient themselves, with the hospice staff, with the doctor, that everybody comes into an agreement. And the other thing that sometimes happens is somebody may be receiving hospice care at home, and then their symptoms become unmanageable, so that, you know, or very difficult to manage. So they may go to the respite house, but just for 5 days or for a week until things are managed again, stable enough, so then they can go back home. Because that's where many people really want to be,
Right.
is in their home. So, the respite house is just such a fabulous resource, because it's that really you know, home-like, wonderful atmosphere, but really skilled clinical services, so that it can just serve as that resource for people.
Right now, I have been to the respite house, and it is very homey and cozy. And talk about, you know, the way it's set up, if you would, Tara.
So the respite house is a home away from home. It's considered that under our regulations and how people experience it. I think the reasons that it feels so homey is the elements that we brought from the Vermont Respite House, and we were very intentional about things that we brought forth to the McClure Miller Respite House from there. The presence, you spoke with Judy about community, and you were talking about it in terms of community support, but one of the ways that the Respite House exudes community is through our volunteer network. So we have over 400 volunteers in our program overall, and about half of those, about just over 200, serve the McClure Miller Respite House. So they do everything from cook meals to answer the phones, to greet new residents when they come through the door, to show families the way to the room, whatever it is. So I think that that's one of the reasons that makes it incredibly home-like, not to mention the environment. I mean, it's a very familiar, cozy,
It's a lovely place, and as I said, it is extremely cozy. And I know one of your volunteers very well, Ducky Donuth.
Oh.
Ducky is a marvelous woman. She has volunteered for respite care for years now, and Ducky always comes. And I think she makes one meal a week, but I know that she comes to fix Christmas dinner.
Yes.
Ducky's amazing. I was after her potato pancake yesterday, but she wasn't
Her
there.
latkes are absolutely delicious.
Yeah, and she's wonderful.
And Ducky is also a financial donor to the to the Respite House. She supports Respite House in all kinds of ways.
So if you give a gift to your agency, you can designate it for hospice, for the Miller McClure?
Absolutely.
Right, yeah. Now, let's talk a little bit more about this. What creates coziness? What creates it? It's not just good care.
No.
Right.
No.
I would say it's the community element and the love. I mean, I don't think you can teach love. I think the people who work at Respite House, who volunteer at Respite, and not just Respite House, but within Hospice, within our full program, the volunteers and the staff come there because they're driven by the mission, because it aligns with their personal and professional values, and they want to be doing that work, and it shows in everything they do.
But in addition, I just want to say, because I was at Home Health and Hospice when the house was built, so much care went into thinking about windows and furniture and colors and where the flower beds would be, and just, you know, so much care went into really trying to make it feel like it is not an institution.
Yeah.
It is not a healthcare facility. It is a home.
And it's in a place where people can get outdoors.
Exactly.
It's beautiful grounds.
And it's
We have 2 gazebos that are handicapped accessible. People can
Great.
get to them in a wheelchair.
great. That's wonderful.
Yeah.
That's great. Flowers, all those good
Yes,
things.
yeah,
Yes. Judy, everyone is continuing to talk, I will say, about health care reform
Yep.
and the cost of health care. Now, this is always an ongoing thing.
Yep.
How can home care and hospice, do you have a vital role to play in any of these goals?
Yeah, absolutely. When people talk about healthcare reform, they also often mention the triple aim or the quadruple aim. And what that is, it's the goals of healthcare reform, and those are to improve the patient's experience of getting the healthcare, improve their health outcomes, and then also to lower the cost, or at least control the costs of healthcare services. When we say quadruple aim, we're also talking about supporting our staff who provide those services. So when you think about healthcare, as we said earlier, there are times when people really need to be hospitalized. But hospitals are the most expensive setting for healthcare. So through healthcare reform, we're finding more and more ways to help people avoid hospitalizations or to avoid being re-hospitalized after they've had a hospitalization. And home care, what we can do is, because we see people in their home, we help them learn how to take their medications, understand what their disease process is, how to manage it themselves. There are just so many ways that we can support people so that they are able to either manage their condition at home, sometimes people have chronic illnesses, or learn how to avoid going back into the hospital or having to use an emergency room. We do a lot of new programs. One of the things I mentioned was longitudinal care. Mm-hmm. That's one of the ways that home health really adds value to the system.
Well, it sounds to me like, in addition to all this hands-on care and technical care, that you're also doing a lot of healthcare education. And that's what we all need to cut down costs.
Exactly right.
Thank you very much for coming. Thank you for the good work you do.
Thank you,
and
Kay.
Thanks for coming again. And thank you for joining us on Conversations with Kay.